I would request Dr. Kalpesh Kawar to introduce our next speaker.
Thank you. Thank you so much. I would like to thank Dr. Anish Chandrana sir first of all for the excellent on showing the benefit of good blood pressure control. Now the next talk will be by Dr. Piya Balani Thakkar, who is a diplomat of American Board of Endocrinology, Diabetes, Metabolism and Internal Medicine, MD in gynecology, DNB, and currently she is working as a consultant endocrinologist and diabetologist in Bombay Hospital and Medical Research Center. Her today's talk will be on learnings from the SGLT2 inhibitors for empowering the ASCVD patient outcomes in type 2 diabetic patients. Over to you, Dr. Piya.
Indians and type 2 diabetes have an age-old intertwining relationship. From the thrifty gene genotype that we have inherited from our ancestors, we are what we call thin fat Indians. We have at our base insulin resistance, which is 1.5 times more than our Western counterparts. This results in diabetes getting diagnosed at a much younger age, almost 10 years earlier. This also, therefore, contributes to developing complications of diabetes at a younger age, often encroaching into an economically productive age group of people. This also comes in spite of a lower BMI, thinner limbs. It's associated with a higher visceral adiposity, often starting off, in fact, even in the early 20s, and therefore contributing to type 2 diabetes at a much higher rate in us as compared to our Western counterparts. So type 2 diabetes is not an isolated disease. It is, in fact, a continuum associated with interrelated diseases of ASCVD, heart failure, and CKD. So what starts out as diabetes with its cohort of hypertension, obesity, dyslipidemia, all of these diseases together result in a vascular insult, which ravages our blood vessels, resulting therefore in microvascular and macrovascular complications. From the kidney point of view, microalbuminuria, macroalbuminuria, CKD, and end-stage kidney disease, often needing renal replacement therapy. And from the point of view of the heart, atherosclerosis results finally in subclinical CAD, manifests as an MI and stroke, causing LV remodeling, heart failure, all of this finally terminating in a cardiovascular death. The recently presented CAPTURE study in EASD 2020, this year was the 56th session, basically said that atherosclerotic CVD affects nearly 1 in 3 patients with type 2 diabetes. And in fact, CAD is the major CVD burden in type 2 diabetes, affecting patients with diabetes, congestive heart failure, CKD. And so, like we're coming to realize, type 2 diabetes, the microvascular complications might start off once diabetes starts off in itself, and the diagnosis is made in itself. But the atherosclerosis predates the diabetes onset, often starts, in fact, at the same time pre-diabetes is laying its foundation, and therefore progresses as type 2 diabetes progresses. CV death therefore accounts for 2/3 of all deaths in patients with type 2 diabetes. And therefore, when we have to target the treatment, this has to be a multifactorial approach of CV risk reduction. It's not only targeting diabetes with blinkers on. Of course, for that, we have to meet individualized targets, A1C targets being less than 7% for most patients. Treatment-wise, we have a plethora of agents available to us. BP lowering, again, has to be aggressive, less than 140/90 or 130/80 even in higher CV risk patients, with the use of various agents, again, ACEs, ARBs, CCBs, and thiazide-like diuretics. Aggressive LDL lowering to less than 100 or less than 70 for patients at higher risk. And for that, in fact, statins, ezetimibe, and PCSK9 inhibitors also available. And finally, weight loss, smoking cessation. But now, in addition to all of these traditional approaches that we used for the standard of care treatment, we have newer agents that basically help to modify and improve the cardiovascular renal metabolic risk. This includes the statins, MRAs, ACE inhibitors, ARBs, as we know of old. But now, in the last few years, the GLP-1 RAs showing a reduction in MACE, CV death, and albuminuria, and the newest kids on the block are the SGLT2 inhibitors, with accelerating effects in terms of their metabolic and cardiorenal benefits. So let's follow and track the whole SGLT2 inhibitor story. What happened over here is that in 2008, with the whole debacle of rosiglitazone and the whole Steve Nissen story, the FDA basically mandated that all newer glucose-lowering drugs coming into the market needed large-scale cardiovascular outcome trials to show that there was no excess cardiovascular risk. This started off with the gliptins, the GLP-1 RAs, and then the SGLT2 inhibitors. The first big trial that came out with a big bang was the EMPA-REG outcome in 2015, following its not only cardio neutral, but the cardio protective effects that it showed. In 2016, the recommendation came out that EMPA was recommended in patients with type 2 diabetes to prevent or delay the onset of heart failure and to prolong life. So this is the first time we have something that can actually prolong life beyond glucose lowering as well. This was then quickly followed then by the Canvas program, the Declare to Me 58, the Credence trial, which was the large-scale kidney outcomes trial as well, followed by the Virtus CV and a host of trials which basically established that the SGLT2 inhibitors weren't a class of drugs to be restricted to diabetic patients alone, but their benefits could be extended beyond to patients without type 2 diabetes as well. And this was purely because of its immense cardioprotective and nephroprotective effects as well. This is where it all started. The first time empagliflozin in the EMPA-REG outcome showed a 38% risk reduction in CV death. And as you see, the separation of curves started extremely early and was sustained as well. The MI risk basically decreased by 21% in the EMPA-REG outcome. The MACE events basically again reduced by 22%. And finally, like you see over here, the onset of clinical benefit for hospitalization of heart failure or CV death happened very, very early, right from day 27 onwards. This was indeed very exciting. So this is a summary of all the baseline characteristics with all the different SGLT2 inhibitors that we have available right now. More than 45,000 patients studied. Average times of their trials were anywhere between 2.5 to 4 years or so. And like I'd like to point out to you, the important part, established CV disease with the EMPA-REG outcome and the Virtus CV, where 100% of patients had established CVD. In the Credence study, half of the patients had established CVD. So this was basically a wide variety of patients, either with CV risk factors or established CVD, that was being studied across the spectrum of these trials as well. And again, with kidney function as well, whereas the previous trials had maybe lesser percentages of patients with kidney dysfunction, the Credence trial, which was the first large-scale kidney outcomes trial, had almost 60% of patients with a GFR between 30 and 90. So with regards to MACE risk reduction, what this basically showed that with the different SGLT2 inhibitors, the reduction in MACE wasn't necessarily a class effect. With the EMPA-REG outcome, basically there was a 14% reduction. With the Canvas program, again, an 18% reduction, but the Virtus CV, like you see, was not significant. For patients without ASCVD, however, while the Canvas and Declare to Me 58 did not have any impressive outcomes, the Credence trial showed a 32% reduction in MACE reduction for patients without ASCVD. The CV death risk reduction, again, inconsistent results, but overall there was a decreased risk for patients with CV death, primarily driven by the EMPA-REG outcome. For patients without CVD, again, it was the Credence trial that basically drove all the results. What has been consistent, however, for the class across all the SGLT2 inhibitor studies is one thing, is that the hospitalization for heart failure results with the use of SGLT2 inhibitors is indeed impressive. So like you're seeing over here, for patients with ASCVD, a 30% reduction, without CVD, a 37% risk reduction, and this indeed was huge. As a result of which now, since 2016, the guidelines have rapidly and progressively evolved, recommending the use of these drugs with or alongside with the GLP-1 RAs, not only for their diabetes, but for their cardio, renal, metabolic benefits. In 2015, where the indication was primarily for glycemic control, in 2016, this extended to CV and mortality benefits for the first time. Like we said earlier, the drug EMPA is prolonging life. In 2018, this becomes benefits with chronic HF, seen across the board with all the SGLT2 inhibitors. In 2019, the kidney gets added on, nephroprotective effects of the drugs as well. And in 2020, what was huge is that the guidelines said, independent of the baseline HbA1c, if in case a patient had ASCVD, HF, or CKD, the drugs, GLP-1 RAs or SGLT2 inhibitors, became the standard of care. And this is what is reflected here. Like we're seeing with the ADA 2020 guidance in the standards of care, the first line of therapy remains metformin. However, once metformin is given, and if the patient has established ASCVD, CKD, or HF, if any of these conditions are present, the standard of care right now is that we must give the patient the benefit of a GLP-1 RA or an SGLT2, or we will not be practicing correct medicine anymore. In terms of other needs, like if we have a compelling need to minimize hypoglycemia or to cause weight loss, GLP-1 RAs and SGLT2 inhibitors with their good extra glycemic benefits as well are on top of the rung over here of this ladder as well. In my opinion, cost is a major issue. There's no doubt about this, that these are expensive drugs. Can't be afforded by every patient of ours in India. But I would think that today, if I can prevent the complications of diabetes, today, if I can prevent hospitalization due to these complications, which is what is the major cost that's driving, the cost in diabetes. I think if today these complications and hospitalization is preventable, we really need to give it thought whether use of these drugs early on for prevention of complications is worthwhile. We always have to mention benefits of drugs alongside with their adverse effects. So bear in mind that SGLT2 inhibitors need a little bit of thought and good patient selection at the time of prescribing. With regards to the SGLT2 inhibitors, a risk of amputation, though of course this was not seen in the CREDENCE trial when good foot care was taken, a small risk of bone fractures. DKA, a 0.2% risk has been seen. It's small, but again, we need to keep it on our radar. Genitourinary infections are the single commonest side effect that bothers us and bothers our patients. And we need to, of course, look after quality of life sometimes and get the agents off if they are recurrently causing quality of life issues. We have to be careful giving these patients who are fragile, volume depleted, perioperative, hypotensive. Got to be careful about the use in these patients as well, and the risk of Fournier's gangrene kept in mind. With the GLP-1 RAs, well, thyroid C-cell tumors is something that we should know about. And of course, the commonly encountered gastrointestinal side effects that will bother patients from 2 days to 2 weeks, extending up to a month. Many patients will settle down after that, but it can remain a persisting problematic effect with many patients as well. Finally, where it comes to the treatment algorithm for selecting drugs for patients with type 2 diabetes with CKD, lifestyle therapy, as always, remains at the top. Following that, metformin is considered first-line therapy. If the GFR is less than 45, we've got to reduce the dose. A GFR less than 30, metformin needs to be discontinued. For dialysis patients, metformin is not recommended. In terms of SGLT2 inhibitors, we have to understand that though they are nephroprotective, and here we are using them for patients with CKD, however, the use of SGLT2 inhibitors need an intact kidney function to work because they are working basically via glycosuria and they're kind of removing fluid excess as well. So as a result of which, if the GFR is less than 30, we should not initiate SGLT2 inhibitors. And these drugs, of course, are not recommended for patients with dialysis. Following that, well, GLP-1 RAs remain the preferred drug for patients with CKDs, and all our drugs after that. I'm not going to go into these details today. Well, finally, what I'd like to say is that the art of medicine is a matter of perspective. Today, when we're treating diabetes, it should not be, for me as an endocrinologist, also can't be just a glucocentric approach. I think all of us as doctors who are taking care of patients with diabetes need to look at the overall picture. if there's a patient with, cardiac disease, kidney disease, I think this is all one single hybrid specialty that all of us doctors looking after patients with diabetes need to understand this whole new field of diabetocardiology to give the best outcomes, the best protection, and modifying the risk of event rather than treating the event once the disease has occurred, once the event has occurred. That needs to be our new paradigm of management. Thank you very much.
Thank you, Dr. Piya.